Okay, good morning, everyone. Before we start, we'd like to acknowledge the traditional owners of the lands we are on today and pay our respects to their elders past, present, and emerging. Thanks for joining us for the September Journal Club. Our speaker today is Dr. Teresa Wozniak, a research fellow and lead in the Antimicrobial Resistance and Disease Surveillance Group at the Menzies School of Health Research in Darwin. And her topic today is antimicrobial resistance blind spots, strengthening disease surveillance and response in regional Australia. I don't think Teresa can hear me, so I will type that I've finished the introduction and then she will start her presentation.
Okay, good morning, everyone. It appears I can't hear anyone, but thank you to Arjun and to Ankas for inviting me. I suppose I didn't really hear the intro, but I thought as a little bit of background to essentially how I started my research to be focused on antimicrobial resistance. It was mostly in health economics, and it was around the time that the O'Neill report came out about the devastating impact, both health and economic, on the globe due to antimicrobial resistance. And I developed a model to try to determine what the additional cost of resistant infections would be compared to susceptible infections in Australia. And clearly, as any model would have it, there were obviously a lot of assumptions that were made, but it was very much dependent on the data that you were putting in is the data you would get out. And it became very apparent very early on that actually we were quite limited in our understanding of the health burden of antimicrobial resistance in Australia. And of course, then that would make things very difficult to be able to determine what the economic burden would be if we didn't really understand what the health burden was. And even more so, it became quite evident that the data we did have was largely from metropolitan areas, and there was this really large area in the centre of Australia where there were single studies coming out about this high burden of infectious diseases and then antimicrobial resistance, but it wasn't being captured in any sort of systematic way. So this program of work around trying to strengthen disease surveillance and response in regional Australia really sort of started out that way by trying to improve the way we capture health and economics of AMR. And so when oh gosh, no, I can't even move slides. Okay, oh, there we go. Okay, sorry about that. So when I say Northern Australia, this is the region I'm talking about. So essentially anything north of the Tropic of Capricorn, and it covers the 3 jurisdictions of Western Australia, Northern Territory, and far north Queensland. So this region is a very unique and a complex region. Skin infections are extremely common in Northern Australia. As much as 75% of community members will present to a clinic with skin or soft tissue infections, and it is the most common indication for antimicrobial treatment. Both nurses and doctors prescribe in the community clinics. A recent paper by Will Cunningham found that Aboriginal health workers or Aboriginal health practitioners who are actually licensed to prescribe antibiotics are not necessarily prescribing them in the samples of community clinics they looked at. And across the region of Northern Australia, there are some differences in who's prescribing what. So that study found that Queensland, it was mostly doctors that were prescribing antibiotics, whereas in Western Australia it was sort of half-half doctors and nurses, whilst in the Northern Territory, in the community clinics, it was predominantly nurses that were prescribing antibiotics, and as much as 72% were actually nurses. Approximately 45% of children in the Northern Australian region have impetigo, This is really alarming. 95% of kids before the age of 1 would have had 1 script of antibiotics, and as much as 50% would have had at least 6 scripts before their first birthday. So you can see where this is going. There's several examples of how that sort of high antimicrobial prescribing would have clearly impacted the development of antimicrobial resistance. One example is in the early 90s, fusidic acid was used to treat impetigo for kids in the Kimberley region, which led to a rapid increase in Staph aureus in that region. Subsequently, the local guidelines, the CARPA guidelines, requested that this is changed, and then that led to a reduction in resistance. There's also significant use of azithromycin to treat bronchiectasis and sexually transmitted infections, and that has shown to lead to resistance in some of the pneumococcal strains. So there's a couple of examples of studies that come out of this region. As I said, methicillin-resistant Staph aureus rates are very high and exceedingly higher than the rest of Australia, as much as 50% from some of these single studies. Azithromycin resistance in Staphylococcus pneumonia. This was a study that looked at long-term azithromycin use for bronchiectasis. And those kids, interestingly, obviously had reduced Haemophilus, but what that then resulted in was a significant increase in macrolide resistance in strep pneumoniae compared to the ones that were not treated on the long-acting macrolide. There's an emergence of studies showing that there's emergence of gram-negative resistance in urinary tract infection pathogens. And I think many of you would know that probably in the last 20 years or so, a lot of the work that Steve Tong has been doing around the ST93 methicillin-resistant clone that emerged from remote Northern Australia and region actually has been identified in other parts of Australia and internationally. So, you know, it is a very complex region, and I suppose it's important as a bit of background, which is why I am providing you this. It's just to sort of understand the context of this region. So demographically, it's very unique to the rest of Australia. Approximately 25% are Aboriginal and Torres Strait Islander. So this compares to a national average of 3%. So much higher proportion of Aboriginal and Torres Strait Islander people live in this region. Approximately 50% live in areas that are considered remote or very remote. There's a couple of studies that have shown the extremely high staff turnover. This study in particular looked in remote community clinics and found that approximately 20% of nurses or Aboriginal health practitioners remained working at that particular clinic 12 months after commencing. So only 20% remained after those 12 months, and actually half of them left after 4 months. So those remote clinics are very small and they have very high staff turnover. And obviously, as you can understand, this would then incur significant higher costs for service provision, would compromise long-term stability for the region, costs, and most importantly, suboptimal continuity of care. There's also limited capacity to diagnose, and that's both because of expertise, microbiological expertise, and actually physical diagnostics laboratory facilities. It is a very geographically isolated area. And this was a study that was published last year, which actually showed how unique the Australian, I suppose in terms of travel, how far it actually takes for patients to travel to hospitals this is by road. And if we focus, I don't know if you can see my cursor, but if we focus on the Northern Territory, and even up the top, this area which is coloured orange here. It's the remote area of Narrabri or Arnhem Land, and seems quite close to be to adjoining Darwin region area. But even between those areas, it takes as much as 11 hours to travel by road to get to the main hospital. So actually, the way that patients get to hospitals is by medical evacuations, and that's a very common form of patient transport. And I was actually, when I did live in Darwin, was very surprised to see so few ambulances in this region. And you can see that, you can appreciate that those sort of medical evacuations are very costly. This was a study that looked at the sort of costing of medical evacuations, and found that a 1 hour return retrieval is almost $9,000, and this was a few years ago. So if you do get to hospital, when you do finally get to hospitals, then you see this sort of cases of patients that are infections that are considered essentially normalized infections. So this is an image of a 16-year-old boy who came into hospital with obviously very clear signs of scabies, which is a mite, and you can see an image there of the mite. Active scabies as well as scar tissue. So, and this boy was considered to be a healthy male. So clearly it's, what I'm trying to raise is that it's a very complex region, not only for the type of infections that are there, but also the underlying comorbidities and conditions that are so significant in many of these patients. So it's very much a challenging region to be able to do any form of, to be able to optimize the use of antimicrobials and track resistant infections. But as many of you know, we do have a national passive antimicrobial resistance surveillance system. And I have on this map sort of represented sites. So these are not individual sites, but areas where the stars is an area essentially where we collect some information about antimicrobial resistance. So it's not necessarily single sites. And you can see that there's this clear area in the center that I would consider to be a huge problem and a blind spot for surveillance. And there's a number of challenges that are not unique to this region or not unique to Australia, why we don't track antimicrobial resistance properly. And that can be a factor of limited reporting. So these are some of the challenges that we've identified. There's a lack of data standardization. The surveillance data are held either in primary health clinics or hospitals, and the data is not necessarily shared appropriately. And then the consequences for that are significant for a number of reasons, but the biggest challenge that we found in the Northern Australian region is really essentially that because no data is coming out of this region, it is severely underrepresented in national statistics and for national planning and containment of antimicrobial resistance. So onto my actual project. So essentially I'm trying to find these surveillance blind spots and by strengthening surveillance. And I always like to go back to the original definition of what disease surveillance is, because I think is quite, it's a quite wordy definition. I won't read through there, but I think there's a couple of things that are pretty important to note in terms of what disease surveillance is. Not just a matter of counting cases. It has to be ongoing and systematic, and that's the main thing that I want you to get out of this slide. There's lots of other things that it does, but it needs to be ongoing, it needs to be systematic. And then the next thing is that it needs to be timely. The data needs to go to those people that need to know. It needs to be disseminated properly. So what did we actually do to be able to try and improve the way we do this disease surveillance? We used digital technology essentially to deliver timely data on antimicrobial resistance. So we developed this geospatial tool that I've called Hotspots, partly using the logo of Hot North, because this work originated while I was working as a research fellow for Hot North. So hotspots is identifying pockets of hotspots, essentially across the region. We have data on hospital and community, on clinically important bacteria. We have data for more than the 4 organisms that are listed there, but in terms of complete data across Northern Australia, these are the 4 organisms that, that we have data on. So Staph aureus, E. coli, Klebsiella, and Pseudomonas. So this is the data flow process for hotspots. Essentially the solid lines are the stuff that we've done, and the dotted lines at the bottom are the things that we're still are still in progress. So it's essentially the pipeline of how data goes into hotspots from the laboratory information systems. It goes through a pipeline where we deduplicate and do data cleaning. The data comes in 2 different formats. So either it will be as an interpreted, interpreted resistant, intermediate, or susceptible, or it will come as an uninterpreted value, MIC value. So we have, depending on which one of those formats, it will go through a coding system that will then interpret those values if they are the uninterpreted ones. We then validate the data against hospital antibiograms, for which we do have data for example, Royal Darwin Hospital and some of the other hospitals. Then we can analyze it by year, by location, by site of infection. We are increasingly getting more data and more interest from other pathology providers, and the providers that have already contributed their data. They're increasingly interested in providing more variables. So the most basic variables that we can, analyses that we can do, are the number of tests, the proportion resistant, trends over time, but increasingly we're getting things like age and gender as well. And then we upload it onto this interactive hotspots tool. We engage with end users and apply it to action. So this is the screenshot of a soon-to-be live hotspots tool. So I'll just run you through a couple of the features there. This particular version that I'm screen sharing now, is essentially using dummy data, so the data there is not accurate in any way, but just for the purpose of this presentation to show you what are some of the features. So essentially it's a map. You can select human clinical isolates. With time, we're also in conversation about including animal isolates. You choose to look at a sample that has come either from the community or from the hospital. So that's on the left-hand side. You can see, click on the overall, the hospital or the community. Then you can look at site of infection. So we have data from bloodstream infections, urine swabs, and respiratory for Pseudomonas as well. And then the drug-bug combination and year, and the year, obviously, you can choose which year you'd like to visualize on this static map. So if we look on the top, so that's the map view. The next, if we were to click on the plots, so this feature will provide plots by region, by age, and by gender. And we're looking as well to include some of the other data other work that I've been involved in terms of the health economics aspect of antimicrobial resistance. And we recently had a paper accepted that estimated the morbidity and mortality of antimicrobial resistance in Queensland. So that was using linked data of hospital and pathology for all of Queensland public hospitals. So we've got estimates of what the death risks are, for example, additional length of stay. So we're looking at perhaps within the plot section to include that data as well for the Queensland region, which is where we've got the morbidity and mortality estimates for. Then the next tab is the methodology, and that clearly is fairly self-explanatory. So that's important, obviously, to look into that tab, because there is still some variation in terms of how susceptibility data are interpreted. So there's the CLSI or the UCAST method, so there is some differences, and that's clearly stated in the methodology section. Then we go across to this tab called Download Report, and that is going to provide the user with an option to do a summary report or a more extensive report of whatever it is that they may be interested in. We also have news and publication and so forth. So really it's an opportunity, I think that it's an opportunity to consolidate a lot of data on antimicrobial resistance. Antimicrobial prescribing, perhaps even that would be something that I'd love to have a chat with NCAS about. You know, and an opportunity to have this all in the one place. So this was a paper that we published recently. The concept, essentially demonstrating the concept of using hotspots as a surveillance tool. So we used, we demonstrated the epidemiology of Staph aureus as an example of how you could use this digital platform to track the spread of resistance in a high burden region of Northern Australia. So for this publication, we had developed a prototype, so it looks a little bit different to that one. The prototype essentially does the same thing. It visualizes and the susceptibility patterns and trends over time. So at the time of publication, we had data on retrospective data on clinical specimens from across the region from 3 out of the 4 main pathology providers. So we had over 1 million AMR tests for a period of about 10 years. But importantly, we didn't have the 4th pathology provider who is now on board and sharing their data with hotspots, and that's the community clinics from Northern Territory. So that data just didn't, essentially just didn't come in time. And some of the other pathology providers didn't provide us with a proper sort of line listing of data. So all of that now has been improved. But essentially, I thought it would be an opportunity to share this publication with you as well. Since it is a journal club, I figured I might as well put a journal up there. So these are the sorts of things that that we published. So just to take you through, so obviously it's just showing the Northern Australian region, so one part of Australia. The grey areas shows essentially where at the time of publication we didn't have data to populate that map. So if we start in 2015 at the bottom of that slide, the proportion of resistant staph, for example, in blood, which is the left-hand panel, has increased in Western Australia. You can see that the change in colours going from yellow through to orange, and then 2017, you know, the Pilbara region in particular has gone into this really quite a dark red colour, quite an alarming colour. So there's definitely geographical variation with Staph aureus susceptibility across this entire region. The left-hand panel shows the blood samples and the right-hand panel shows swabs. We, interestingly, actually, for the Northern Territory, all the blood samples are essentially all patients with blood infections are being treated in Darwin. So that's why the data is essentially only available for that region, but not the swab infections. And that's why we've got data for other regions in Northern Territory. The the proportion essentially of, this the main purpose of this is really to demonstrate geographical variation. MRSA ranges from approximately 46 to 50% in Western Australia to 26% in Queensland, and an overall in 2017 the overall rate for the tropical region was 35% resistance to methicillin, resistance to Staph aureus. So that's approximately, for the international people dialing into this meeting, that's a twofold higher proportion of MRSA than reported in southern parts of Australia, and that's taking the overall. Clearly, in some parts of Western Australia, we see these pockets of high infection that's above the average for that region. So we can also look at resistance patterns such as clindamycin and cotrimoxazole. This is showing one of the outputs by jurisdiction. So there's Western Australia, Northern Territory, and Far North Queensland. It's showing us time trends and the proportion resistance for those 3 antibiotics there. I think, you look at Far North Queensland and you think, oh, all the infections are going, it looks like methicillin is perhaps going up. But then if we look at different sites, clearly the middle panel is the bloods and the bottom panel is the swab. We can see that that increase in Far North Queensland is mainly in the swab samples for methicillin, and the blood samples are actually decreasing. So I think important to note that, the more granular you go into the data, the more sort of better understanding you can get, obviously, clearly. So if we go back to that CDC definition of improving disease surveillance, we sort of try to do with the hotspots tool, we're trying to make sure that it's ongoing and it's systematic. Like I said, the data was retrospective, but plans for the future are that it's prospective. So the next thing we had to tackle was, well, who needs to know in this region? And this essentially was a year-long evaluation of hotspots tool that was done by Laura Goddard, who was one of the Masters of Applied Epi students with me at Menzies, along with a lot of other people providing lots of input into this project, which has been really kind of exciting and interesting to see how this develops. We came up with sort of 3 main main people that need to know, but clearly there's continually, we're seeing that there's more people that might be interested. The top of the list are those health professionals, so that can be GPs in clinics are interested in using hotspots, especially interested that the data in hotspots includes non-invasive isolates like urines, for example. Healthcare professionals in hospitals, they're interested as well, probably interested in it a little bit less than the GPs, maybe because the hospital health professionals already have access to antibiograms, although surprisingly, when we did visit a few hospitals that were more remote, we were quite surprised to see that people didn't necessarily have access or didn't know where to find the antibiograms data. So for the health professionals, this year we have employed an AMS pharmacist in the Northern Territory, an absolutely amazing pharmacist and thinker, and a person that I would consider a champion for change, and she's absolutely amazing, and she's spearheading a lot of the work around trying to implement hotspots in practice. So she's using that platform, or will be using the updated platform once we finish it during the ward rounds as part of the stewardship activities in the hospitals, and as well as connecting back to the community clinics. So it's essentially a model of the way this Champions for Change is essentially a model for implementing hotspots into practice. The other people that are key end users of hotspots would be policymakers, and that could be in the form of a number of things. Clearly the AMR strategy, we're working closely with the Commission to make sure that we're not duplicating efforts with what the APAS and AURA programs are doing. We want to make sure we're adding value rather than duplicating or trying to be the first ones to get to whatever it is, the endpoint is. So this year we're in conversations with the Commission to perhaps include hotspots in the next year's report. The other thing is as well using the data from hotspots to inform an update of the guidelines. The local guidelines are the CAPA guidelines, and they're the guidelines that are used across all of Northern Australia, unique for the region because clearly the infectious diseases, that region does need to have its own set of guidelines. So we're wanting to include hotspots in that discussion as well. And then there's the international community and obviously sharing the data between jurisdictions, but as well between countries. We live in a very, we live very close to a lot of the countries that are that have AMR and endemic AMR, and clearly we need to better share that data. So I actually thought the next one would be a breather, but I'm not sure that I can hear anyone. Or maybe that's been fixed, but I thought if anyone had a question up to this point, that would be great. Let me see if there's Q&A. Okay, I have a question. Is the resistance tracking program available to search live by health professionals on the ground? If so, how? Where is it? Great question, Fran. So at the moment, so like I said, that the prototype that we developed where we published that paper that I presented, that was live for a period of time. But then we realized, but then we were able to secure some funding to essentially do an upgrade of that tool. So at the moment, we're just going through an upgrade of hotspots, and we've essentially put that website as under construction. So it will be an open access platform. The data will be, we will be essentially launching the platform once the new upgraded version is available. And it will be accessible for everyone. There will be some restrictions in terms of who can download data, and that will probably be people that provide the pathologies, the data custodians will have access to more data than obviously people going in through the open access portal. But it will be live probably by the end of the year. So I have another question. Thanks, Belinda. Is there further information on data accessible on the nurse prescribing? So the nurse prescribing, is that the study that Will Cunningham, are you referring to the study that Will Cunningham published about nurses prescribing more in the Northern Territory than other sites? So that, I can share that publication if that's the case. We don't actually, yes, yeah, so it's just that publication. I can share that publication. So it was Will Cunningham recently looked at, did an audit of, I believe it was 5 clinics in each of the 3 jurisdictions. So in total, he would have had 15 clinics. And they did an audit of the types of antimicrobials that are being prescribed, who's prescribing, and appropriateness. So they used the NAPS tool to apply it to the remote clinics. So that's a great publication. I'll definitely share that at the end of the talk. Are there any other questions? Okay. Well, I'll keep that open just to make sure that I see if there are any other any other questions. That was just a couple of photos, just to give you a bit of a break from not me talking. It's from the Kimberley region. It's a wonderful, wonderful region. I'd recommend anyone to travel there. I do have one more question. Okay. What were the most important factors in encouraging data sharing by private pathology labs? Great question, Catherine. Look, I think so. I have to say, so I think it's because I was essentially there. I was living in Darwin and had formed really excellent relationships with all the pathology providers. So not only the private pathology providers, but as well the hospital ones. You know, I think there's that sort of sense of, you know, building their relationships before you're actually asking them for something. So really the project, you know, has come to a lot of fruition now, but it took probably about 2 years of lots of meetings and, in a sense, lots of discussions around, you know, why we think this is important, what the pathology providers will get out of this just as much as what the Hotspots project will get out of it. Look, we had criticism, we had ups and downs. I mean, there's lots of people that considered a project like this, which is essentially a public health. It should be something that's probably done within public health, population health, rather than a typical academic institution, which is where, you know, Menzies is essentially, although unique, it is essentially a research institute, but the project isn't your typical research project. So there was a lot of relationship building, essentially, and I think once the pathology providers saw that we're not only taking data from them and not necessarily giving them back anything, I think that's when a lot of the progress really happened. And then once they were on board, once we found the right people to contact within those pathology providers, then really it's just been a wonderful collaborative project. It's a lot of work, but it's been really rewarding. And you would have perhaps seen that the publication, the author list, you know, is quite a long author list because we included all the pathology, the people that essentially provided the data for us from the pathology services. So I would say the important factor would be good relationship building and a way of essentially trusting each other in the process. So I hope that's answered your question. Okay, so then I think, so then the thing I sort of wanted to, maybe not going to have too much time to talk about this, but this was just something that, like some early data that I wanted to share with you, and I'd love to have a discussion. It's such a shame I can't hear what you guys are saying because I would have preferred this to be a discussion rather than me reading. You know, back to this prototype that we developed that was in, so this was from the publication, and you can see that, you know, there's clearly the changes in the proportion of MRSA were sort of regionally concentrated and didn't follow what we thought might be more of a grading across that area. So you can see that, you know, the Kimberley's got this really bright red, you know, yet Mackay in far north Queensland is green. I mean, is it really just sort of probably indicating this, that there is community transmission in these sort of confined niches, and perhaps there's something else that's contributing to driving these hotspots of infections. Clearly, antimicrobial prescribing is one thing, and that's a really important. It's really important to try to ensure that we are prescribing appropriately, and that all those stewardship programs are active and happening. But there's clearly, in my mind, there's got to be some community transmission there that's facilitating the transmission and spread of antimicrobial resistance. And I think considering what the social context is of that region is really important. And it's important not only to manage those patients, but as well in the future to mitigate risk of spread. So this is something that is sort of floating around in my mind, and we've just done a couple of very, very preliminary work studies around this, where it's essentially trying to better understand what the drivers of infections are. And if I can just go back a step and sort of this slide, essentially you would probably all would have heard antimicrobial resistance compared to climate change. And I think the front page of the National Geographic really made a great impression on me. So if I can take this analogy of this peak of the iceberg with antimicrobial resistance, I would put antibiotics that we take at the top, and that's the stuff that we, although lots of other things are happening as well, really that's a lot of the focus in antimicrobial resistance is about prescribing and antibiotics. And clearly that it has a huge impact on the emergence and spread of antimicrobial resistance. But then Peter Collignon, a couple of years back now, did this study, global study, looking at perhaps there's all these other drivers, you know, like the quality of governance, the amount of money we actually put into antimicrobial resistance, infrastructure, poverty. That's at the bottom of the iceberg, and these are not as clear cut and clearly not as easy to test as something like antimicrobial prescribing. So we have done some very preliminary analysis using the hotspots data set and overlaying it with published data on social disadvantage. So sort of tackling more that sort of poverty side of it, which you know, are more sort of around the social determinants of health, essentially. Not necessarily a novel concept with infectious diseases, but I think it's, you know, it's the way forward to actually making a significant impact in Northern Australia, because I think there's a lot of sort of complexity in how we tackle antimicrobial resistance up there. Surveillance is one of them, but there's a lot more, and antimicrobial prescribing is one, but there's a lot more happening that we know very little about. So this is just showing us the analysis that Karen from University of Melbourne is doing, using infectious disease modelling overlay using our hotspots data set. So she's done some analysis for Queensland, for that far north Queensland region, and essentially, I don't want to overstate too much, but the aim of the study was to see what the contribution of social determinants of health were, and we found that the proportion of, this is showing third generation cephalosporin resistance E. coli, that it was correlated with social disadvantage. So we hope that these sort of studies will inform some of the discussions of the potential mechanisms by which some of that unequal, you know, those pockets, those niches of hotspots, why they occur and persist in that region. So in conclusion, there's essentially three main things I touched on today. There's this cost of, I think the cost of inaction is higher than the cost of action. I didn't present any of the health economic stuff. That's probably for a whole new other thing. But so there is clearly the cost, the healthcare cost, but there's the human cost, which I think is probably more pertinent. And we know that the weaker the surveillance system is, the less knowledge we have, that health authorities have, and essentially public health have, together on how these diseases are spread. And at the moment, rural and regional Australia have very weak surveillance of antimicrobial resistance, and I think that's resulting in more infections that are costing the healthcare system a lot, and a huge cost to the patient and society more broadly. Secondly, I think we need to consider social drivers. So there are multiple factors that facilitate disease spread. I didn't really go into this today very much, but just a as a bit of a primer for sort of this discussion, that I think, you know, this idea that if we reduce antibiotic consumption, that it will be sufficient to contain AMR. That might be the case for certain areas, but I think certainly we've seen in Northern Australia those pockets of infections. You know, I don't think antimicrobial prescribing is the only thing that's driving there. And I think, you know, in that respect, it's essentially even more important for me to consider what the social drivers are for the work that I'm doing, because if we look at the overall status of most Australians, people living in parts like Northern Australia, regional and remote areas, they continue to experience much worse health outcomes. They have much higher antimicrobial resistance rates, as I've shown you, as you know, as much as 50–60% of MRSA, and therefore it's sort of, you know, there's social inequalities there, there's health inequalities there, and I think that's the sort of thing that I'm touching on with that aspect of the presentation. And then the last thing is maintaining momentum. You know, there's a significant burden of antimicrobial resistance. We clearly know that if we detect it early and provide timely data and appropriate response, you know, this platform could expand to other settings. But you know, what we have started here essentially needs to be maintained, and I need to make sure that my program of work and hopefully the broader discussion around improving surveillance and response, you know, needs to sort of percolate to governments. So I'd like to thank lots of people, but I think foremost the pathology providers, and I've listed the 4 main data custodians there: Northern Territory Pathology, Western Diagnostics, Pathwest, and Queensland Pathology. It really wouldn't be this project wouldn't happen without them, without their support, and without them trusting us in this process. And I think we touched on some of that with that question that we had. And there's lots of people to thank, but Will Cunningham, I think he's doing his PhD. He's also the data manager for hotspots. You know, he's been absolutely amazing with this program, along with Laura Goddard, who did the evaluation. Karen's doing some of the stuff on social determinants of health, and it's been kind of exciting having that collaboration with University of Melbourne and with Karen. Then there's all the people at Menzies, and particularly Hot North. So Kevin Williams, Bart Curry, and Ralph, you know, their advice has been absolutely amazing. And Hot North for essentially giving me the opportunity to take an idea from inception and go with it. I mean, it was an amazing opportunity to work to get the Hot North Fellowship, and now to a prize for my next 2 years of fellowship that I have. So thank you.
Thanks a lot, Teresa. That was a fantastic presentation. I don't think you can hear me, but everyone else can. If you'd like to ask any more questions, please feel free to type them in the Q&A. There's a question.
I have a question. A paper from the UK looked at genomics and found transmission of staph in wound clinics. Could there be healthcare transmission in hotspots? Do you mean, could we measure healthcare transmission in hotspots, Leslie?
Yes, I think Leslie's talking about transmission in clinics in healthcare settings rather than...
Does MRSA transmit in clinics?
Yep.
I think the transmission, short answer would be I don't know. I would say that a lot of transmission happens in back in the community. So I think, you know, what we see in hotspots is essentially probably as well just the tip of the iceberg, because a lot of the, you know, a lot of patients don't even end up in in clinics, they you know, because of the number of reasons that I've described around, you know, difficulty traveling and the geographical sort of isolation and, you know, some of those sort of cultural reasons why people don't necessarily go to clinics. I think there's a lot of stuff that we don't know. So I actually don't know. I think a lot of transmission happens within the communities. And certainly, you know, housing and overcrowding is has been shown to be one of the facilitators of transmission of some of those skin and soft tissue infections. You know, patients coming in with scabies, and more often than not, I would say a lot of the household members would have scabies as well. But I'd be interested in that paper that, that you're talking about, Leslie.
Okay, thank you everyone for your participation today, and look forward to seeing you at the
Are there any other questions?
Journal Club. All right. I will type my thank yous to.
Okay. Thanks, everyone. I think, yeah, that was great. It's a shame I didn't get to actually hear any of you or see any of you, but yeah, contact me if you want to ask any further questions, and I'd love to hear more comments from you about the presentation. Thank you for listening.
All right, perfect. And thank you everyone for attending. Thanks everyone. Bye.